Thank you, Chitra. At the outset, I would like to thank AIOS, particularly Chitra, for the kind invitation. I would say that Chitra has covered most of the things which I had in mind. Because of the time limit, I wisely decided I will not talk about the managing failures, which she has covered it beautifully. I will talk about three important complications that one can see following a trabeculectomy, that is aqueous misdirection, blebitis, and with the endophthalmitis, and the late bleb leaks. So aqueous misdirection is something which is rare, but it can happen, especially in eyes with angle closure. To understand aqueous misdirection, having a good knowledge of anatomy and physiology of the eye, particularly the middle segment of the eye, is important. So what is the middle segment? Middle segment is the ciliary body, lens zonular diaphragm with the anterior vitreous. And this part is important. I will come to that. And usually when the aqueous is produced in the from the ciliary processes, it goes in the conventional route. Other than that, part of the aqueous also goes posteriorly to the vitreous cavity. So there is always a balance between the normal flow of the aqueous in this way. And what does this balance is maintained by? This is maintained by proximity of the ciliary process to the vitreous body and the permeability of the hyaloid phase. These two will get compromised whenever there is a aqueous misdirection. So factors that are responsible for the aqueous misdirection most of the times are related to the size of the eye. So it is common with hyperopia because eye is small. So what is the initiating factor for the aqueous misdirection? Most of the times it is the sudden decompression of the anterior segment of the eye where the middle segment collapses. When does it happen? It happens any surgical decompression, that is doing the trabeculectomy in a small eyes, or it may be in the post-operative period because of the post-operative overfiltration. Even a wound leak, it causes the sudden collapse of the anterior segment and the middle segment, results in aqueous misdirection. So what happens when there is aqueous misdirection? The conventional flow gets compromised and the aqueous tends to go posteriorly. Because of that, there will be, this happens because of the collapse of the middle segment. Because of this, there will be forward displacement and progressive obliteration of the middle segment, and this keeps increasing and the vitreous gets swollen up and it causes the expansion of the vitreous, and this will result in shift of the lens iris diaphragm anteriorly and causes the flat anterior chamber, and whatever aqueous is being produced, it tends to go posteriorly, not a drop will go to the anterior part. So it becomes a very difficult condition to manage. So what do we see clinically whenever there is aqueous misdirection? We see axial shallowing of the anterior chamber. That means absolutely no anterior chamber and the entire lens iris diaphragm has moved forwards. There will be presence of the patent PI. That's how we differentiate it from the pupillary block. There will be usually elevated intraocular pressure, except in cases where the bleb is still functioning, you can have aqueous misdirection even with the normal intraocular pressure. And one should make sure there is no other cause for the lens iris diaphragm shift anteriorly, that is mainly suprachoroidal fluid or the blood. So if you see here, this is an axial shallowing of the anterior chamber. You see here absolutely no anterior chamber. The entire lens iris diaphragm has, in this case it's pseudophakia, has moved forwards. And it's basically disease of exclusion. So what are the diseases you like to exclude? One is, the first and foremost is the ciliary block, pupillary block. Second is the choroidal effusion. Third is the suprachoroidal hemorrhage. How do we differentiate pupillary block from malignant glaucoma? They both will have the shallow anterior chamber. If you examine carefully with the slit lamp, in the pupillary block, you will still have space between the lens and the cornea, and in the central part you will have space, whereas with the axial shallowing, it is a uniform shallowing, there won't be any space. That's how you differentiate looking at the antechamber depth, the pupillary block and aqueous misdirection, or popularly called as a malignant glaucoma. When can it happen? It can occur any time after surgery, and in important times usually following suture lysis, or when you keep patient on cycloplegics, especially the small eyes, that is angle closure eyes. Whenever you stop, there is a possibility the lens iris diaphragm will move forwards. It can cause aqueous misdirection. How do we diagnose? You have to do a detailed slit lamp examination, gonioscopy, especially for the other eye, to know whether the angle closure is the cause for it. Do a good indirect ophthalmoscopy to rule out the effusions like a choroidal effusion or the hemorrhagic choroidals. And if the view is not good enough, you need an ultrasound to rule out that problem. And to rule out the leak, do the CIDLs to rule out the leak. And as I mentioned, B-scan ultrasonography if needed, if you can't see the fundus in detail, to look for the choroidal detachment or suprachoroidal hemorrhage. Ultrasound biomicroscopy plays a huge role. If you are able to do it, it shows the anterior rotation of the ciliary body with opposition to the ciliary process to the lens equator. This is how it will look like. Ciliary process have been rotated anteriorly, and you can see the plant antechamber here, and it is abutting against the lens iris diaphragm here. And you can see sometimes in the same clinical picture with some amount of suprachoroidal effusion, which you may miss it with the clinical examination and also on the ultrasonography because it is too peripheral. And here, choroidal effusion is contributing to the shallow of the anterior chamber. Probably these eyes will likely to respond to medication. It is one of the prognostic factors. If you see the choroidal effusion, you can afford to wait with the conservative treatment for a longer period of time. Whereas if you see a clinical situation like this, and these eyes most probably will require surgical intervention, they may not respond to your conservative treatment. And this is A-scan photographs showing a axial shallowing. That's how the entire lens iris diaphragm has shifted forwards with the expansion of the vitreous. So when we are managing it, make sure you are dealing with aqueous misdirection, re-establish your diagnosis. Start with the mydriatic cycloplegic therapy. YAG hyaloidectomy can be considered, and vitreous surgery is considered for eyes that doesn't respond to conservative treatment. And management of the fellow is very important because that needs a lot of planning and also convincing patient how important to take care of the other eye to avoid aqueous misdirection in the future. So what are the mydriatic cycloplegic therapy? Basically, AC deepens due to the relaxation of the ciliary body and the tightening of the zonules. Initially, the treatment was with 10% pinenephrine and 4% atropine, but it was abandoned because of the systemic side effects because of the high 10% pinenephrine and 4% atropine. The recommended drugs now is 1% cyclopentolate or tropicamide with 5% pinenephrine initially, and then followed by 1% atropine for maintenance. Substantial risk of recurrence when they are stopped should be kept in mind. Sometimes we may have to keep patients on cycloplegics for longer periods of time. And control the intraocular pressure with beta blockers. And one may have to consider hyperosmotic agents if the pressure is very high, basically to reduce the vitreous volume and improving its permeability. So IV mannitol is recommended. These eyes are likely to have a lot of inflammation. Use the topical steroids to reduce inflammation. This is an example of an eye that responded to the mydriatic therapy. You can see axial shallowing, flat antechamber. With the treatment, how beautifully the antechamber has formed and things have got stabilized. Coming to the hyaloidectomy, because the vitreous becomes impermeable and there is a need to disrupt the anterior hyaloid phase. If you want to do the hyaloidectomy, what is required is clear view is very essential. Usually, when you do the YAG laser anterior hyaloidectomy, you have to wait at least for 24 hours for the effect to happen. And if the eye is pseudophakic or aphakic with the posterior capsule, capsulotomy also is needed along with the anti-hyaloidectomy to establish a communication between the posterior segment and the anterior segment. And this is an eye which had a misdirection, had a large PI with the pseudophakia. And following the capsulotomy and hyaloidotomy, patient responded well to the therapy. And on scan biometry, you can see this AIOS OCT, you can see a good communication between the posterior chamber and the antechamber. Because of the hyaloidotomy, there is some amount of vitreous prolapse into the antechamber also. And this has restored the normalcy, and the antechamber has deepened with the treatment. Coming to the vitreous surgery, the principle here is removal of the hyaloid barrier, then the removal of the vitreous. You should make sure that you will remove the anterior hyaloid phase. That is, you have to break the anterior hyaloid phase and also establish a communication between the posterior chamber and the antechamber. Basically, you are making a eye into a single chamber to avoid aqueous misdirection happening even with the time. The initial procedure was recommended by Chandler's operation, and it can be done by anti-segment surgeon. But with the technology what we have today, and nobody does the blind Chandler's operation, most of the times it is the pars plana vitrectomy. And this is one of my colleagues who has helped me to do the surgery here, and it is a pseudophakia in an angle closure eye where the phacoidal trap is done. She developed aqueous misdirection. You can see that after the vitrectomy, and what is done here is, I will just forward it, and you can see creating a opening in the iris and removing the capsule and establishing a communication between the posterior chamber and the anterior chamber. So you are converting the eye into a single chamber. Unless you do this step, the relapse of the aqueous misdirection is likely to happen. So whenever you deal with a surgery like this has to be done. And it becomes easy to do this in a pseudophakic eye. In a phakic eye, majority of the times we do the cataract also along with it. If you are not in favor of doing removing the lens, then at least we should break the anti-hyaloid phase. That is very critical, and make sure that the PI is patent in such a situation. You can see here how the chamber is connected with the anterior chamber. And coming to the other eye management, once it happens in one eye, the chances of it happening in the other eye is very high. If there is narrow angle, aqueous to be done. Whenever there is surgical intervention is needed in that other eye, we have to make sure that we take all the precautions to avoid any sudden shallowing of the anterior chamber. So you have to form the chamber well on the table. Postoperatively, laser suture lysis or releasable sutures has to be handled very carefully, and these eyes have to be kept on cycloplegics for a longer period of time. So this is in brief about the aqueous misdirection. The second thing Chitra has already covered. I will just go through the second complication that we can see with the trabeculectomy, that is blebitis and bleb-related endophthalmitis. What are the risk factors for it? Trabeculectomy at the inferior site has a higher chance. Use of the antimetabolites has resulted in thin cystic blebs. So the risk has increased, and in the past, people used to do full thickness procedures for better control of the IOP, and those eyes are at a higher risk to develop infection. And you can classify them into mild, moderate, and severe. What is mild? Bleb infection, but no antechamber or vitreous involvement is called mild. Moderate bleb infection with antechamber inflammation, but no vitreous involvement. Severe is bleb infection with antechamber and the vitreous involvement. So how do we manage? This is just the blebitis without antechamber involvement. And it is an ophthalmic emergency. Take the conjunctival swab, start the intensive topical treatment, and carefully monitor the patient. You need not admit the patient, but you have to monitor almost twice a day if needed till things subside. The moderate one, we do admit the patient. It's an ophthalmic emergency, and the conjunctival swab will be taken. Along with it, topical, we give even the systemic drops, and very careful monitoring is needed. The severe grade, we take the vitreoretinal surgeon help also here, admission with the topical and systemic antibiotics, close monitoring. We may have to take a AC tap to culture, to send it for the culture. intravitreal antibiotics are needed. If it is very severe, a diagnostic and therapeutic vitrectomy also is mandatory. And this is a blebitis resolving with the topical medication the 5th day of the treatment, and it has cleared totally with the time. The only problem is whenever the blebitis resolves, there is a possibility the blood can fail. So you have to keep a close watch on the intraocular pressure. How do we prevent? Patient education, to tell the patient unnecessarily not to touch the eyes, not to rub the eyes, any conjunctivitis, to see a doctor immediately, and they should not use the contact lenses. I tell all my patients not to swim because you can never be sure how the swimming pools are maintained. There are some people who believe in giving a topical antibiotic at the start of the symptoms to the patient. They caution the patient, ask them to keep an antibiotic ready in hand as and when needed to start up the medication. Usually we don't do that. We ask them to consult the doctor as soon as possible. Chitra has already covered about the blood leak. I think I will just quickly look at these are the two types. One is a localized leak and the diffuse leak. And we used to see a lot of blebs like this because of the limbal-based flap, because limbal-based flaps gives localized thin cystic blebs with a steel ring around it. Whenever the bleb increases in size, suddenly it gives way. Nowadays, with the modifications in the surgical techniques, where fornix-based is done more often, and with a aim to obtain a more posterior diffuse blebs, we don't see this kind of blebs anymore. So it is a small video where I'm using for a localized leak a autologous blood injection. After cleaning the anterior cubital fossa with a cubicle and syringe, patient's blood will be withdrawn, and using a 27 gauge or 30 gauge needle away from the bleb, the needle will be inserted into the center of the blood where the likely leak is, and then inject the blood, and this blood will block the leak and can result in closure of the leak. It works well only when there is a localized leak. When you have a late leak with a diffuse leak like here, this may not work. Then in such a situation, you may have to go for what we call it as a bleb excision. You have to excise the entire bleb and take a conjunctival autograft, usually from the inferior quadrant. So after excising the bleb, if there is necrosis of the sclera, you may have to reinforce the sclera either with the partial thickness flap from adjacent to it or the donor sclera, and undermine the conjunctiva well and take a little larger than the what you have dissected superiorly, the conjunctival autograft from the inferior quadrant, place it limbus corresponding to the limbus, and using a 10-0 nylon sutures, you close it tightly. And one advantage of with this is your blood function will not get compromised. This is how you manage a large leak because of the late leak due to the trabeculectomy. So these are the three complications I thought I can share with you all in detail.